Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam from Houston, Texas. This is Cardiology seminars. We have more than 160 videos on various topics in cardiology on our YouTube channel, which you can browse at your leisure. The feature presentation is Heart Sounds, focus on second heart sound. Variations in second heart sounds are of great clinical significance because they are favorite topics for cardiology and medicine boards. So if for nothing else, you need to understand the concepts behind variations in the second heart sound, so you may be able to answer those 2 or 3 questions you're going to get in your medicine or cardiology boards. But it's a good way to understand the pathophysiology and also the effects of hemodynamics on the variations of the second heart sound. As you know, the second heart sound is produced by the closure of the pulmonic valve and the aortic valve during the slow ventricular ejection phase, which we covered in the cardiac cycle video, which you can watch. So I'm going to be talking about splitting of the second heart sound, normal versus pathological. We're talking about changes during respirations, changes during disease conditions, reversal splitting, wide splitting, and single second heart sound. Normally, there is a slight time variation between the closure of the aortic, represented here in red, and the pulmonic valves. But it is so minute, we may just hear it as However, you can exaggerate that by taking a deep inspiration. When you take a deep inspiration, there is increased venous return to the right side of the heart, which delays the right ventricular emptying and hence the closure of the pulmonic sound, producing a much closer than what I'm trying to show. So this delayed closure of the pulmonic valve is the major effect leading to the splitting of the second heart sound during inspiration. Along with that, because of the expansion of the lungs, there is venous pooling and less blood return to the left side of the heart, thus causing an early closure of the aortic valve, which is a minor effect causing for this split during inspiration. During expiration, the whole thing changes or reverses, causing a narrow splitting of the second heart sound. So that is during normal conditions. So we're going to look at these various other conditions. So let us start with wide splitting of the second heart sound. Before I go into the wide splitting of the second heart sound, I want to use this heart diagram to explain the normal splitting of the second sound during inspiration. During inspiration, there is more venous return into the right side of the heart, thus increasing the volume and the time it takes to eject into the pulmonary arteries, thus delaying the closure of the pulmonic valve. And similarly, as I explained, there is pooling of the blood in the lungs during inspiration because of expansion of the lung, and that causes an early closure of the aortic valve. Now let's talk about conditions where we might see wide splitting of the second heart sound. Looking at the concept of inspiration, because I'm more interested in having you learn the concepts than just trying to memorize, okay, wide splitting, use like an acronym like RWLPP. Instead of that, I want you to understand the concept. The concept is anything that increases the volume, anything that increases the ejection phase of a particular chamber, be it right or left, delays the closure of that particular valve. In this situation, anything that increases the right ventricular function, anything that delays the right ventricular function, such as right bundle branch block, because of the delayed activation of the right ventricle, the pulmonic valve closes much later than it's normally supposed to be. Similarly, a WPW, which activates the left side first and then the right side, we see the same effect as right bundle branch block. Or if we are pacing the left ventricle, which is very uncommon, pulmonic stenosis, where there is prolonged ejection phase that can also delay the second heart sound, and of course pulmonary hypertension. All these conditions which cause the delay in the right ventricular ejection phase and valve closure leads to wide splitting of the second heart sound. It could be like lub dup lub dup lub dup dup. One important thing is the pulmonic second sound is best heard in the second left intercostal space. So if you really want to appreciate the splitting of the second heart sound, you need to put the stethoscope on the second left intercostal space. The right second intercostal space is for the aortic valve, and that's where you hear the aortic sound and the murmurs that radiate to the neck and to the apex. As far as pulmonic valve is concerned, it has to be listened on the second left intercostal space. Okay, let's look at the fixed splitting of the second heart sound. Any condition where the right ventricular volume is sort of fixed, it doesn't change very much with inspiration or expiration, then we're going to get a fixed splitting of the second heart sound. So understand the concept. When the volume is not changing during inspiration and expiration, and when there's an increased volume on the right side, like in patients with atrial septal defect or ventricular septal defect, pulmonary hypertension, or right heart failure, where the volume is already maximum and you can't change it with respirations, then we are going to get the fixed splitting of the second heart sound. These are all very important points that you need to remember, the concepts, because there are going to be questions on boards. Now, here is the paradoxical splitting of the second heart sound. Let's look at the first one. As I told you at the beginning, we get the aortic valve closure first, followed by the pulmonic valve closure. And during deep inspiration, because of increased venous return, there is a delay of the pulmonic valve closure, causing a wider split. But what about conditions where we get paradoxical splitting? That is, the pulmonic sound comes first and the aortic sound comes afterwards. Anything that delays the left ventricular ejection phase, left ventricular activation, leads to paradoxical splitting. I want you to memorize the concept. Anything that delays the left ventricular activation. What can delay the left ventricular activation? A typical case would be a right ventricular single chamber pacemaker, or if you have a left bundle branch block where the activation of the left ventricle is considerably delayed, maybe like 100 to 120 milliseconds. Similarly, if you have WPW, which is activating the left ventricle last, or in a case of aortic stenosis, where there is prolonged ejection phase because of aortic stenosis, then we can get paradoxical splitting of the second heart sound. There are conditions where we can get a single second heart sound. Obviously, if you have critical aortic stenosis, where the leaflets are barely moving, your valve area is like 0.5 centimeter per meter square body surface area, you may not hear the aortic second sound, and you may hear like a single sound. Or if you have severe aortic regurgitation where the second sound is muffled, you may not be able to hear the splitting of the second heart sound. And of course, congenital pulmonic valve absence can lead to the absence of the pulmonic component. So in summary, we need to understand the concepts more than memorizing what condition causes what. Before I conclude, I would like you to get a free copy of my Cardiology Rounds manual by sending us an email to drniknikam@gmail.com. This has been a presentation of a cardiology seminars brought to you by Triple N Media. I am Dr. Nik Nikam from Houston, Texas, and please do subscribe to our YouTube channel, and I will see you next time.